all ready for all of you. Already, that's great. Now I have 172, so we still have quite a few people to join. Can chat with everyone. Guys can chat with everyone. So we'll give it a couple of minutes. It's still 6 o'clock. And we'll start having people online now. HRT and breast cancer. That's great. Good evening, everybody. And good evening from Bordeaux. So me and Peter Barry was one of the surgeons of the Marsden. We're stuck in Bordeaux. We were just finishing the ESSO conference, which was a great event here. And it's great to have everybody online. It's a different topic we tried today, because we don't want always to keep on talking about technical issues and about treatments for breast cancer. This is, I think, more for important survivorship issue, and it's something that not everybody, most clinicians don't understand HRT and breast cancer that much. So we have a great speakers and great panelists. We have Francesca Poggio from Italy is going to talk about HRT and breast cancer survivors, which is a very important topic, and they've written a beautiful meta-analysis from Italy. Then we have Hisham Hamid, and Hisham was my previous boss in Guy's Hospital in London, and Hisham does lots of the risk-reducing surgery, so he will talk about HRT in gene carriers and high-risk patients. Then we'll have Tuvik Yoldemir from Turkey. He's one of the professors from Gynae, and he's going to talk about managing the menopause in breast cancer patients. Then we have Lia Sketsa from Sweden in Uppsala, who's one of the oncologists that's going to talk about managing the side effects of hormone treatments. And when we're talking about hormone treatments and HRT, we always need another gynecologist. So we have Maggie Banis-Polukovsky, who's one of the gynecologists and also a breast surgeon. It's great to have Maggie on board for the discussion. We need also a patient advocate, and that's why we have Terry Kuti from the States. Welcome, Terry. And we need also, of course, a nurse, because most of those side effects are dealt by a nurse. And we have Jen Murphy, who's also from breast cancer now. So welcome, everybody. The talks will be 15-minute talks, so we'll finish the talks in about an hour, and then we'll have a discussion for about half an hour to an hour. If you have any questions, please put it on the question and answer section. Otherwise, it might be missed. You can see that's already we have 270 people. We're expecting to hit more than 300 hopefully today. People will join in a bit later, and that's it. So we'll start with the first speaker, and we have Francesca. Francesca, do you want to start sharing your screen? The next 15 minutes are all yours.
Do you see the presentation?
Yes.
Okay, thanks to the organizer for this kind invitation. My topic is about the role of hormone replacement therapy in breast cancer survivors, focusing on our meta-analysis on this topic published recently in Breast Cancer Research and Treatment.
Francesca, I think you're muted.
Yes, yeah.
Yeah, okay. Do you hear me?
Yes, we can hear you now. Okay.
Sorry. Due to the significant improvement in early detection and the treatment achieved over the last years in the field of breast cancer, the large majority of women with a previous history of early stage breast cancer can expect long-term disease-free survival. So the topic of the survivorship is becoming more relevant. Recently, also the ESMO published guidelines on this topic, and it is very important for oncologists and for all the specialists to address the potential long-term and late effects of treatment that survivors will face in their life after diagnosis of breast cancer. Particularly, symptoms of iatrogenic and premature menopause induced both by chemotherapy and endocrine therapy are frequently reported by breast cancer survivors. Estrogen deprivation results in a so-called genitourinary syndrome with hot flashes, weight gain, insomnia, fatigue, early onset of osteoporosis, depression, and musculoskeletal disorders. These side effects have a detrimental impact on patients' quality of life, and these side effects can lead to increased rates of early treatment discontinuation with consequent poorer prognosis. In healthy women, the impact of the use of systemic HRT in influencing the risk of developing breast cancer remains controversial, with findings discordant. The effective impact of systemic hormone replacement therapy in breast cancer survivors in terms of the risk of breast cancer recurrence has been more complex to face, and to date, no conclusive data on this regard exist. Nevertheless, international guidelines on this topic state that systemic hormone replacement therapy should not be indicated in women with a previous history of hormonally mediated cancer. So, to better elucidate this issue, we performed a quantitative synthesis of randomized controlled trial to assess the safety of systemic hormone replacement therapy in terms of disease recurrence among breast cancer survivors. Our work was done and reported according to the PRISMA guidelines for reporting of systematic review. We performed a systematic literature review by searching relevant publication in PubMed library up to April 2021. To be included in our meta-analysis, the study should meet these criteria, should be studies including breast cancer survivors, randomized controlled trials exploring HRT as an experimental treatment, publication reporting the risk of breast cancer recurrence in terms of hazard ratio between patient exposed and patient not exposed to HRT, studies only published in English and involving adult patients. The first objective of our meta-analysis is to assess the safety of systemic HRT in terms of disease recurrence among patients with breast cancer. A random effect model was used to calculate the risk of breast recurrence, reported as a pooled hazard ratio with 95% confidence interval. An hazard ratio above 1 indicated an increased risk of breast cancer recurrence with the use of this treatment. Moreover, we also performed a subgroup analysis to estimate the risk of breast cancer recurrence according to both hormone receptor status and type of systemic HRT. These are the 4 studies included with a total of 400 patients. We can see that the first trial by Vassilopoulou and Sellin included only hormone receptor negative breast cancer patients. The other 3 trials included both. Moving to the results, in terms of the risk of recurrence overall, as compared to the control group, the use of systemic HRT significantly increased the risk of breast cancer recurrence with an hazard ratio of 1.46, statistically significant. At the subgroup analysis that we performed, including the 2 studies that evaluated this treatment also in hormone receptor positive breast cancer patients, we can see that the risk of breast recurrence with the use of systemic hormone replacement treatment was significantly increased in this subgroup of patients with an hazard ratio of 1.80, with a significant statistically significant. Considering only the 3 trials with the hormone receptor negative patients, we can see that the risk of breast recurrence with the use of systemic HRT was not significantly increased in this group of patients with an hazard ratio of 1.19 that cross the 1. So, in conclusion, our meta-analysis observed that among women with a previous history of breast cancer, the use of systemic HRT showed to be associated with a significant increased risk of breast cancer recurrence with an hazard ratio of 1.46. An increased risk of breast cancer recurrence with this treatment appeared to be statistically significant only in patients with hormone receptor positive tumors with an hazard ratio of 1.80. Therefore, we concluded that this approach remains contraindicated in breast cancer survivors. Future research should be focused on alternative safe intervention to mitigate the symptoms of iatrogenic and premature menopause for these patients in order to improve adherence to our oncological treatment with maintaining an acceptable quality of life. So I want to present also this very interesting review published by the group of Matteo Lambertini that is a review on the evidence-based approach for the management of side effects of adjuvant endocrine therapy. The author concluded that the approach for the management of the side effect should be multidisciplinary, and it will become more relevant in the near future, and the growing attention to the proper management is likely to become essential, and it should be shared with the patient at the moment of the prescription of our therapies. Thanks.
Thank you for that. And it's great talk, Francesca, up to the point. And it's a beautiful meta-analysis. So if anybody is dealing with breast cancer, they really need to have a look at that paper, because I think many people started changing practice. There will be lots of discussion. I'm sure that Hisham will have lots of questions about that when we come to the discussion. Now, the next speaker is Hisham. And
yes, and very happy to introduce Professor Hisham Mohammed, who's a senior lecturer at Guy's and St. Thomas's Hospital. He's been there for many years along with all the other team there, and he does a lot of risk reduction mastectomy there. And we really welcome his talk, which if you want to share your screen with us, Hisham, that'd be great.
oh, that's great.
Right. Can you see it now?
We can see it, but it's still not a full screen, Hisham. So if you want to press on the play, and that's great.
Yes, the play here is an arrow, and I'm trying to find it because it seems
it's just above. It's just
yes,
above.
here I found it.
That's great.
Yes. First of all, thank you so much for inviting me, and it's really great pleasure to be with this elite gathering of scientists and specialists. In actual fact, is the webinar is very timely because just over the past few days, the issue of the menopause has been under the spotlight in the media. So, well, I hope that we will come out with some informative results to share with the public as well. Obviously, you are aware that there are lots of risk factors for breast cancer, but I listed what is considered as relevant for our discussion today, the genetic issue and the family history of breast cancer, as well as the reproductive history and the female hormones. Since obviously you are aware that since the discovery of the high penetrant genes, we have had wealth of knowledge, and we started to understand what happens with breast cancer, the pathway, the mechanisms, and so on. But there is no question that this discovery has posed even more challenges for us, not only because we've become aware of what this high penetrant genes lead to the increased risk of breast cancer, but also because of the other relevant organs as well, which has some impact on the management of the breast cancer, as we can see here from regarding the ovarian cancer point of view. Not only that there are also other panels of high penetrant genes, which is started to contribute to also a wider range of women. Some of these genes only lead to increased risk of breast cancer, not necessarily to ovarian cancer. So therefore, what these women are facing, that ultimately one day or another they are going to endure the problem with the menopause, either through the natural course or as a result of having a risk-reducing oophorectomy. I think for us to come to some conclusion, and I'm sure there will be a lot of discussion we are going to share, is that some understanding of the role of the estrogen and progesterone in the process of breast cancer. When we were in the medical school, things were very simple. We felt that, or we understood, or we were told that the estrogen is the offender and the progesterone is the protector. But obviously, this nowadays has proven to be absolute sort of wish-wash of evidence or talks. We can see that the issue is very complex. It is not only that we are talking about the primary molecules of estrogen and progesterone, but we're also talking about the effect of the metabolites. Not only that, what we are talking about in terms of the estrogen and progesterone, but even the effect and the outcome vary according to the duration of use. And it has been highlighted that even with the pregnancy and the production of massive level of estrogen and progesterone, it has a protective effect, whereas even lower level of these hormones over a long period of time is going to lead to actually mutagenesis and carcinogenesis. The issue with the progesterone will in actual fact will become very interesting to raise and discuss in the context of what we are going to talk about later on in terms of the ER and the PR negative tumors. We can see that it is the issue is not a straightforward binding of the progesterone and estrogen to the receptors, but there are lots of other mechanisms which is actual fact is going to trigger not only the development of estrogen and the progesterone receptor positive tumors, but also to hormone receptor negative tumors as well. It was obvious that with the understanding of the impact of the menopausal symptoms on the quality of life of women, then there are lots of, or there have been lots of studies that started quite early over the last few decades to address the not only the benefit but also understandably the risk of use of HRT. And these older studies has actually highlighted one important point, is that the duration of use of the HRT does impact on the risk we are talking about. It was also important that we are not talking about relative risks, but as Francesca mentioned, that if we are going to share the information with the patient, we need to get some information which are clearly understandable, and we are using figures such as how many women are going to develop breast cancer as a result of the HRT, if they are using it for 5 years, 10 years, and so on and so forth. And this data has been also enforced. I'm actually trying to get rid of my picture because it is actually impacting on the slides. This also the quantification of the percentage has been the absolute number has been highlighted in the Women Health Initiative study, and we can see that if we are talking about absolute numbers, we can see that they are still small numbers, and that is something very important that we share with the patients when we discuss it. One of the earliest studies and reports by Rebek, which in actual fact set the scene for what we are practicing now, is that looking at what is the benefit of risk-reducing oophorectomy in terms of reducing the risk of ovarian cancer? Because we all know that it is, as far as the breast cancer is concerned, at least we have some effective surveillance which we can rely on, but unfortunately, even until today, we don't have a reliable screening method for early detection of ovarian cancer. So not only that, he has shown and reported that significant reduction in the risk of ovarian cancer, but also reported at least 50% reduction in the risk of breast cancer, although you are all aware that this is started to be challenged in recent publications. But what is most important, regardless whether the risk-reducing oophorectomy is going to reduce the risk of breast cancer or not, the most important part is that adding back hormones to the women who had risk-reducing oophorectomy did not significantly alter the claimed benefit, or at least it did not increase the risk of breast cancer. And therefore, the conclusion was that short-term use of HRT is safe. And subsequently, there were other studies which started to emerge, supporting certainly the benefit of risk reduction from oophorectomy, but also sharing the what has been reported before, that it is the use of HRT does not significantly increase the risk of breast cancer. But what has started to emerge, and that was the relevance of understanding the mechanism of these hormones, is that the estrogen alone is a safer option for these women than estrogen and progesterone, and therefore there are lots of effort now to trying to use progestins free formulation, such as, for example, the Tebelon Olivier, as commonly known. It is not surprising, and Francesca said that it is you induce acute or abrupt or sudden menopausal or drop in the female hormone by doing risk-reducing oophorectomy. It is hardly surprising that these women are going to suffer from acute symptoms, and the list is endless. Some of it is quite significant and compromise the quality of life, particularly for working women. I see that in my clinic all the time, how these women are actually suffering the most significant side effects. And I've never heard the term foggy brain so frequently as much as the recent days. And also in addition to the long-term side effects and the health issues. Case control studies also has shown that this is the study which has been actually quoted quite frequently, matching pair for the breast cancer and the use of HRT, and therefore there was reasonably matched for the duration of use, and in actual fact the conclusion again supported what we heard before, that short course of HRT should not be contraindicated in high-risk women or mutation carriers. Another meta-analysis again reached the same conclusion, to show that there has been no evidence of increased risk of breast cancer. But again, we need to highlight the importance of reflecting on the type or the formulation of the HRT we are using. And again, this study highlighted that not only that estrogen is a safer option, but it, in actual fact, there was a suggestion that it may even reduce the risk of breast cancer. And again, another study and systematic review has again reached the same conclusion, that the use of HRT, particularly after risk-reducing oophorectomy, did not affect the risk of breast cancer. And therefore, in actual fact, they went as far as saying that for this group of women, we should offer them HRT for the obvious reasons and the quality of life and the rest of it. So in conclusion, that we don't have to emphasize the impacts of the menopausal symptoms on the quality of life. And as I'm saying that particularly there is increasing number of working women and career women and the professional women who actually say, I cannot function in my role and with losing my, if you like, my thread of sentence halfway through. There was no, although there was an increased risk of breast cancer as we saw earlier on in the general population, it was very reassuring and to be honest with you, give us a lot of confidence to say that the women who are at increased risk of breast cancer, there was no interaction between the HRT and their sort of mutations to magnify or amplify the risk more than the general population. Formulation is very important, and then we have to address this really seriously. And there are different, if you like, strategies to see how we can avoid using systemic progesterone. The duration of use also is very important. But I think the message we have to take is that the high-risk women should not be denied, or in actual fact should be offered HRT for the severe menopausal symptoms. Thank you very much indeed.
Very informative and a great talk, Hisham. It's great to have you on board with this. Now we'll go to the next speaker, and it will be Tawfiq Yoldemir. And Tawfiq is one of the gynecologists in Turkey, in Istanbul, in University of Marmara. He works with a great friend with Bahadir Gulglu, and he's going to talk to us about managing menopausal symptoms for breast cancer survivors. Tawfiq, the next 15 minutes are all yours.
Thank you all for the invitation, of course. I'd like to go over the menopausal symptoms. There were some questions during the talk, so I think some of the issues will be dealt during my talk. So we know that the breast cancer survivors, they kind of have some endocrine drugs after their initial treatments. And we know that the tamoxifen and aromatase inhibitors, they tend to increase vasomotor symptoms and vulvovaginal symptoms in these women. So I would like to go over some treatment options during the 15 minutes that I have. For the vasomotor symptoms, we have selective serotonin reuptake inhibitors. And as you can see here, citalopram and escitalopram, they tend to be used for those who take tamoxifen, and they are considered as first-line options. Then, of course, we have fluoxetine and sertraline, but they tend to interact with tamoxifen, so please be careful when you try these drugs. Another drug group is selective serotonin norepinephrine reuptake inhibitors, and here we have venlafaxine and desvenlafaxine. Again, the first-line options for those who take tamoxifen as their endocrine supplementation. Other than these two groups, we can also prescribe gabapentin in different doses. And clonidine is another option which can be used in dosage 0.1 milligrams per day, and it significantly lowers the hot flushes in breast cancer survivors. Oxybutynin, either as 2.5 milligrams twice a day or 5 milligrams twice a day, again, can be another option. And we have the extended release version, which seems to decrease the frequency and severity of the symptoms. Well, you will say we have these options and we have different dosages. Does that mean that for severe symptoms we need higher dosages? No. As you can see on both of these slides, charts, different dosages for each type of drug has been used, and it seemed to kind of show similar reductions from the baseline when we consider the hot flash score and the frequency. So you have to individualize your treatment to each of the patients that you see. And this is another table that we can see, even though the dosages differ, the time for hot flash improvement and the way quality of life is perceived by the patients, they seem to be similar, even though the dosages are different. Well, which drug seems to be better than the others? There is not such a case. So we see on this table that different drugs have been compared between one another. For instance, venlafaxine was compared with clonidine and gabapentin, and they were shown to have similar patient preferences, similar quality of life perception by the patients. And even in some studies, time for the hot flash improvements seem to be similar. Well, it was considered that giving antidepressant therapy to women might increase breast cancer. And I will try to show you a couple of studies that showed just the opposite. The study that was conducted in 2003, even though it showed that the antidepressant use kind of increased breast cancer risk, when the confounding factors were left out, the significance was lost. It was the same in another study from 2005. And here we see that the ever use of paroxetine, for instance, was not shown to increase the risk. Another study from 1999 look at the numbers, more than 5,000 patients in each study group, and there were no significant difference in terms of breast cancer. Similarly, in 2001, among women, around 38,000 women who used the antidepressants, it was shown that the risk was not related to the use. Well, we have the serotonin and noradrenaline reuptake inhibitors as one group, which were found to improve sleep and quality of life and mood of the patients. Again, gabapentin and clonidine were other drugs that can be used in order to improve these unwanted effects. This is a nice table that will show you the starting dosage of each type of drug that can be used in order to overcome the vasomotor symptoms that we deal with breast cancer survivors. It is best to start with the lowest possible dose and then increase it during the follow-up. Well, body-mind practices is another area. And here we see that cognitive behavioral therapy, alone or with physical exercise, tend to relieve patients from hot flash. And if these are given by therapists, it also was shown that it improved those vasomotor symptoms. Well, what is the logic behind this? These menopausal symptoms kind of will force the woman to social embarrassment, and they will not feel that they are in control of their life. They will have interpersonal conflicts due to the symptoms. So the idea is to give them controls and try to come up with behaviors that would kind of manage them through these times. So the behavior therapy is all about informing the woman related with menopause, vasomotor symptoms, and try to show them what are the precipitants for the vasomotor symptoms and what triggers these, and also help them to deal with stress and help them to learn breathing exercises in order to overcome these times. Hypnosis has also been tried and was shown to work significantly for the relief of vasomotor symptoms. Yoga similarly, in 3 months or time was again was shown to reduce the symptoms. And when we talk about acupuncture, we see that either with physical, with the needles, or with the addition of electricity, electroacupuncture, they were also shown to improve the symptoms in short and long-term therapy, even after 4 months of the therapy. Well, we would think that aerobic training might be of some help, but in studies that are shown here, they were not the case. So aerobic therapy would not be an option. When we talk about the herbal treatments, the plant-derived products, black cohosh was studied a lot, and it was not found to have any significant difference either in the frequency or the intensity of hot flushes, and nor in the night sweats. And the safety profile, even though it is good in general population, and it's not been shown to have any recurrences in breast cancer survivors, the use of black cohosh is considered controversial. Well, regarding phytoestrogens, even though they tend to have less estrogenic activity, and they are shown to be not associated with breast cancer recurrence and risk, again, there is this idea that they can have antagonistic effect when the woman is on tamoxifen or an aromatase inhibitor such as anastrozole. Well, we have some data that actually tells just the opposite. In the Healthy Eating and Living study done in 2011, we see that there is no adverse effects of the soy food intake, either on cancer recurrence or mortality. And even they showed, those women showed to have low mortality. Another study, Shanghai breast cancer study from 2009, showed that the soy consumption kind of lowered the recurrence and death after breast cancer. A study named Life After Cancer Epidemiology, also found that it was not associated with the adverse results. Lignan is another category, and it was shown to decrease breast cancer risk and even reduce the risk of estrogen negative and progesterone positive breast cancers after more than 7 years of the intake. Cholesterol, another group, was shown to decrease the risk in receptor negative breast cancer tumors. So when we consider management of vasomotor symptoms in breast cancer survivors, we can kind of follow this algorithm. On one part, we have the non-pharmacological options, such as cognitive behavioral therapy, hypnosis, and acupuncture. And on the other arm, as you can see, we have all different sorts of pharmacological treatments, like you can choose citalopram, venlafaxine, paroxetine, gabapentin. And the idea is not one drug is superior than the other one. And if one is not tolerated and not effective, then there is a chance to choose another drug as an option, and it's logical to just follow the patients for a month and see how they do behave. And then there is again the option of combining these two pharmacological and non-pharmacological treatments. When we consider vulvovaginal symptoms, we have the option, the first line would be, of course, the moisturizers and lubricants, but they have short-term efficacy. And there was a question in the chat room, how low is the estrogen? Well, we have low and ultra low dosages of estrogen, and the lowest dose might be a choice here. The vaginal estrogen is not associated with systemic absorption after 8 weeks of treatment. So this is a sign that the local treatment is an option. And when gel is used in such a way that after 3 weeks of continuous treatment, if you continue with twice a week application, still the estradiol levels will increase and then normalize after 12 months. And these would remain low afterwards. So with topical estrogen, even after long treatment periods like here in after 3.5 years of treatment, there was no recurrences in breast cancers. But still we are kind of frightened that these might cause recurrences. And it is suggested that if the non-hormonal products are not enough, you might choose the lowest possible estrogen, topical estrogen in certain cases, since the data is limited there. Well, I will show you some studies that were published regarding the local estrogen. Here we have estradiol, estrol 0.5 milligrams as cream. We have the tablets as 25 micrograms, and they showed no recurrences, and they were working well for vulvovaginal atrophy. Well, we have options, vaginal androgens, and vaginal progesterone has been studied in 2 different dosages, and the lowest dose seems to be within the postmenopausal limits. But the thing is, the long-term efficacy and the safety is not available yet. And laser is another option, but it's mostly studied in terms of sexual function, and there is data lacking in terms of safety and breast cancer relapse. Ospemifene is an estrogen receptor modulator, and currently it's not recommended for breast cancer survivors unless the patient has completed her treatment and she is disease-free. Then in those certain cases, you might use ospemifene. And even with those, the estradiol levels remain within normal postmenopausal levels. Well, we have the moisturizers, we have the vaginal lactobacillus capsules working, estriol and estradiol locally used, which do have good data, and lactobacillus coupled with the local estriol also has good data regarding clinical improvement. Testosterone creams were used for the sexual function with good clinical results, and we have fair results regarding laser therapy in terms of vulvovaginal atrophy. Well, this is another summary regarding vulvovaginal atrophy in breast cancer survivors. We have non-hormonal treatments, lubricants, moisturizers, and hyaluronic acid gels, which can be used, but just bear with me, the relief is limited. Then you might consider low-dose vaginal estrogen, even though the intravaginal progesterone, which is the dihydroepiandrosterone, is considered not safe because of the data is not enough. It is might be an option, and ospemifene, although it's not approved by FDA, still it can be considered in those women who have been in remission and they are finished with their cancer treatment. Well, another new drug group is coming into the market, which is neurokinin-3 receptor antagonists, and we have fezolinetant, and studies in the last 5 years have built up regarding the reduction in vasomotor symptoms. And here we have good data regarding the reduction of those symptoms in 12 weeks time. Well, this is just one of the many neurokinin-3 receptor antagonists, but some are going through phase 2. Some could not go beyond because of the hepatic toxicity. But as you will read in the very lowest 2 lines, it might be drug that can be used for estrogen-sensitive cancers, and breast cancer is one of them. Hopefully, when data is safe enough to offer this new drug for this group of patients. Well, I don't want to go over how we deal with osteoporosis regarding the aromatase inhibitors, but this is a very short diagram, flow chart, how you should follow the patients regarding osteoporosis and supplementations that you might consider when they do have those side effects, I would say, from the drugs that they use. And by saying that, I thank you all for your kind attention, and Yazan for his kind invitation so that we could go over these couple of issues together with you tonight.
That's great talk, Tawfiq. That's great talk. There's lots of things to discuss. I'm sure Terry and Maggie and the others will have lots of things to discuss on this talk. Leah will be giving the talk from the oncology point of view about managing the side effects of endocrine treatment. I'm sure that there will be lots of cross points between both talks, but Leah, the next 15-20 minutes are all yours.
Yes, thank you very much for the invitation and the opportunity to, but I must say that my presentation is almost identical with Tevfik's, so we will see. Oh, I have problem with, now you can see the second slide. Yes. We know that there are recent improvements in the survival of hormone receptor positive breast cancer are strongly associated with therapeutic practices or advances, particularly with the uptake of adjuvant endocrine therapy. As we can see, the adjuvant endocrine therapy is the cornerstone for the management of the hormone receptor positive early breast cancer. It depends on the menopausal status. For the premenopausal women, we have the tamoxifen 5 or 10 years, and for the postmenopausal women, the upward aromatase inhibitors, or in those with high risk, maybe they extend the endocrine therapy. I'm going to talk about it a little bit in a few slides. Both endocrine treatment and ovarian suspension are not devoid of adverse events, and when we propose an adjuvant therapy, we must take into consideration the safety profile of every endocrine agent, as well as what the patient wants, the patient's preferences. Francesca have already shown this slide from the Francois article, and here's the different strategies according to the most frequent and disturbing side effects of endocrine therapy. For me and my department, the women that I meet have suffers from hot flashes, musculoskeletal symptoms, and sexual dysfunction, vulvovaginal symptoms that lead to sexual dysfunction. We know that estrogens have activity in multiple systems. Therefore, therapies that lead to estrogen deprivation have impact on different systems, like the reproductive system with vaginal urothelial irritation, dryness, atrophy, incontinence, on the musculoskeletal system with arthralgia, osteopenia, osteoporosis, as well as bone fractures, cardiovascular system, hypercholesterolemia, angina, myocardial and cerebrovascular ischemia, and central nervous system with hot flashes, night sweats, fatigue, headache, depression, cognitive dysfunctions. Tevik already shown this slide. As we can see, patients on aromatase inhibitors have more vulvovaginal symptoms, some musculoskeletal symptoms, as well as fractures, while for the tamoxifen group, endometrial cancer, venous thromboembolism is a greater problem. Now, about the extension of endocrine therapy up to 10 years with or without ovarian suspension, we know that implies a prolonged duration of side effects, as well as an increased prevalence of the rare but serious side effects. For example, in the MA 17-hour trial, the fracture incidence was significantly higher in the extended 10-year letrozole arm when compared with 5 years arm, 14% versus 9%. And in the ATLAS trial, the risk of pulmonary embolism and endometrial cancer were higher in the extended 10 years of tamoxifen group compared to the 5 years tamoxifen group. And the intensification of therapy with OFS is also associated, of course, with an increase of symptoms. And now, what about the consequences of endocrine side effects? Like Francesca shown, can have impact on patients' quality of life, on social functions, ability to return to work with the partner relationship, and they can lead to poor adherence to endocrine treatment, which can impact on outcomes. Many studies have investigated endocrine treatment adherence. In the ATLAS trial design, 2 years after study, only 84% of all patients were still on treatment. And in the combined analysis of text soft trials, over 4,000 patients, 14% of patients in the overall cohort had discontinued endocrine treatment. And they are side effects that can be mitigated through pharmacological and non-pharmacological approaches, as Tevik showed, that should be offered to our patients in a dedicated setting of care. Now I'm going to guide you through the different strategies in order to treat vasomotor, musculoskeletal, and vulvovaginal symptoms. And I'm going to present different aspects of pharmacological approaches, non-pharmacological approaches, and non-hormonal strategies in some cases. about the pharmacological approaches, we all know that the most effective therapy to treat these symptoms is, of course, the estrogen replacement. Nevertheless, it's contraindicated among breast cancer survivors, given concerns of its negative impact on breast cancer recurrence. And progestogens have also been tested among breast cancer survivors to treat vasomotor symptoms. The big suggestion that they represent a highly effective therapy. Indeed, megestrol can reduce hot flashes 75 to 85%, but their mixed data regard the safety of progestogens among breast cancer survivors. In fact, there's evidence of both stimulating and inhibiting effects of progestogens on breast epithelium. We can treat some metastatic patients with progestogens with good results. Tibolone, which is a selective tissue estrogenic activity regulator, evidence suggests that it's more effective than placebo in reducing vasomotor symptoms, but nevertheless, there are safety concerns regarding its use among breast cancer survivors, like the Liberate trial that Francesca mentioned. So we shouldn't recommend these approaches. Like Tevik already showed, so I'm not going to go in details here. It's we have the antidepressants, SSRI and SNRI. Their efficacy was evaluated in a systemic review of 11 RCTs, healthy menopausal and postmenopausal women treated with SSRI versus placebo. The endpoint was improvement of vasomotor symptoms, and they were associated with a statistically significant decrease in hot flash frequency without significantly higher side effects. Like Tevik mentioned, there may be some interference between SSRI and tamoxifen, so SNRI is the preferred option for women treated with tamoxifen. Tevik already mentioned about the cabapentine and brecabalin, were both tested for the treatment of hot flashes and demonstrating efficacy. In fact, there's a study at Bordeaux showed that in a study about postmenopausal women in a small group sequential open-label randomized crossover trial of 4 weeks of venlafaxine versus gabapentin, and both agents led to a substantial reduction in hot flash scores. It was 66% reduction for both agents, but at the end of the study, most women preferred venlafaxine due to the different toxicity profile. With venlafaxine, it was a nausea, appetite loss, and constipation. For gabapentin, dizziness, appetite loss. And Tevik already mentioned the clonidine, so I'm not going to go in details here, and the neurokinin 3 receptor antagonist as well. Other agents like vitamin A does not seem to be effective in the treatment of hot flashes. For me, clonidine, because it was inconsistent results, should be recommended today. And then Tevik already mentioned the non-pharmacological approaches, cognitive behavioral therapy with the MENOS studies, hypnosis, acupuncture. Physical activity was ineffective to treat vasomotor symptoms, but it helps with many other things. Weight control, the Women's Healthy Eating and Living study showed that the women who gained at least 10% of weight from diagnosis had an increased risk of hot flashes when compared with women with stable weight. Then it was the stellate ganglion blockade showed some efficacy. Strategies now to treat musculoskeletal symptoms. pharmacological one is the switching therapy. In clinical practice, it's very common to switch from one aromatase inhibitor to another, trying to reduce the intensity of the symptoms, and it's working quite well sometimes. We can try with duloxetine. It was a randomized placebo-controlled trial of duloxetine for aromatase inhibitor-associated musculoskeletal symptoms in early-stage breast cancer that showed that after 12 weeks, improvements in the duloxetine arm. The vitamin D, there are many studies about this, but all the studies have shown that the serum vitamin D levels were not associated with arthralgia. Glucosamine and chondroitin sulfate, they are both popular dietary supplements used to treat arthritic pain. And in a single-arm open-label phase 2 study, 53 patients were included, and 46% of those patients have had an improvement in pain and stiffness, and there were also reported improvements in function, pain interference severity, and worst pain. NSAIDs and steroids, we can use them, but we don't have strong data that helps. For me, vitamin D and omega-3 acids should not be recommended. About the non-pharmacological approaches now, acupuncture has shown an improvement in the mean worst pain scores, in pain severity and pain interference. Physical activity in the HOPE trial, there were randomly allocated 121 patients to exercise or have usual care, and 12 months, almost a 30% reduction in worst joint pain scores among women assigned to exercise was noted. In the experimental group, pain severity, pain interference, and other codified pain scores decreased significantly, while increased among the usual care group. Now about to treat vulvovaginal symptoms, pharmacological approaches, hormonal. There are some non-hormonal approaches like moisturizers and lubricants, like Tevik mentioned, or ospemifene, and as well non-pharmacological approaches. I agree with Tevik. It's currently accepted that the use of estradiol and estriol vaginal therapy, even among those treated with aromatase inhibitors, can be considered, acknowledging the limitation of existing data and risk-benefit of these therapies. Moisturizers and lubricants and lidocaine could help. About the ospemifene, it's a SERM approved to treat dyspareunia. Nevertheless, its safety and efficacy in breast cancer survivors yet to be established. When the patients suffer from atrophy, stenosis, or pelvic weakness, we can refer them to a specialized clinic, and we can explore options as physical therapy. If they have decreased libido, treatment options can include counseling or even SNRI. Laser therapy, Tevik already mentioned, that can be an option. And here the same article, like Francesca showed, Francois et al. Here we can see that we have data from randomized control studies that all these can help with arthritis. And here is the same, on the same table that Tevik showed. That was all that I had. Thank you very much.
Great. So before we start the discussion, and that this will be a very interesting discussion, I think we will know that we all will agree not to agree on many points, but there's many points that we will need to bring on. So we have Ash Kotari. It's great to have Ash with us today. And Ash is one of the surgeons in Guy's Hospital. We have Maggie Panis Palutowski from Germany, gynecologist, but a breast surgeon. Also, we have Jen Murphy from a nurse from Breast Cancer Now. So it's great to, and we have, of course, Terry Kuti, who's one of the patient advocates from the States. I'm not sure if Francesca is still online. If you're still online, Francesca, you can put your camera on now. I think we need to make sure that we're not sending the wrong messages from many of the talks. It's a very controversial issue in many aspects. It's all about balancing things. It's about shared decision making. There's lots of different aspects of the decision making. As my friend Peter here summarized it, he just told me it's individualized treatment and individualized options, non-hormonal before hormonal and topical before systemic. But let's start with Terry. We need the patient's advocate. We need the view that, because sometimes we as clinicians, we see it only from our side, but what we're doing this mainly for the patients. Terry, any comments from your side?
Thank you, Yazan. So everybody can hear me okay?
Mm-hmm.
Excellent. First of all, thanks for allowing me to be on the panel. I have multiple notes sitting in front of me, so I will just kind of go with it here. First of all, I have to thank all of you for presenting this information. I don't know how you feel as clinicians. It has to be overwhelming at times. All the studies that you guys, yes, I see some nods. All the studies that you have to sort out, and also the studies that you have to think about that you would like to see as well, right? To make improvements in all of this for patients. So in a clinical setting, I guess this is my best advice from a patient perspective, because as I was sitting here, my head was swimming. My head was swimming not only for me, but I've had breast cancer twice, but for other patients. And I think what happens in a clinic setting many times, there becomes, I don't know if any of you feel this, but there becomes maybe a balance of power when the patient comes into a room. I think that the best thing you can do, knowing this topic is controversial, knowing that there are many studies out there, knowing that we're still working on all of this on behalf of patients, which is all of your interest. You wouldn't be on this panel today if that weren't the case. Start out of the blocks in your consult by just sitting down in front of them face to face and saying, I understand that you're in here because you have side effects that you don't like, and you don't know what treatment to use for this. And I want you to know from my perspective that I want to help you sort this out in the best way we can for you. And we know from all of the data, from all of the studies, this is going to be very specific to your needs. So I think the vocabulary that we use with patients to begin to engage them in a shared decision-making process is very important. That's my sage advice on that front. I also highly encourage you, because it's something I practice, I highly encourage you to really push the exercise element. And I know that there have been studies that it improves the lives of breast cancer patients. It helps with, survivorship. What side effects are there to exercise? There's really none, is there? There's really none. And I understand that patients have different interest levels for exercise. Some just simply don't, they feel like they're in treatment or all of these side effects. They don't even want to go there. It's like they're not interested. Give them resources. If you don't have them, give them resources. Encourage them to be in a community that fosters exercise, that shores these women up, even if they start out by walking out their door and saying, today I'm going to start, and I took a 10-minute walk, and I didn't do that yesterday, and then build it from there. Exercise does a number of things. I heard some of you talking about the side effects of osteoporosis. We know that weight-bearing exercises can certainly help with this. And in the overall picture, I think what exercise does for breast cancer patients, it helps them reclaim their body. It helps with self-esteem. It helps how they feel about their body. And in all the times that they have been bombarded with treatment, with surgery, with recovery, with personal relationships due to all of these side effects, going to the gym or not going to the gym, doing it at home, resistance bands, lightweight training, cardiovascular exercise, it can all make small and important incremental improvements for patients. So that's my sage advice. I have one more little shameless plug. If any of you are at the San Antonio Breast Cancer Symposium in December, please look me up. I don't know if any of you are going. I can't even assume that. I will be there. Please look me up. I love coffee. I will sit down, chat. I will sit down and chat with you about this. Yazan, what can I say? Thank you.
Thank you, Terry. Jane and Maggie, just a couple of small comments if you want, especially Jane, can you guide people where they can find more information on the web? You have a great resource in breast cancer now.
Sure, absolutely. Yeah, thank you. It's so interesting. And I think what's reassuring for me, this is something that we hear all the time at Breast Cancer Now on our helpline and our forums about these impacts of side effects of menopausal side effects of endocrine therapy. But on top of, sometimes I think we forget that people may be experiencing not only these side effects, but side effects from other treatments as well. So peripheral neuropathies, chronic pain, and not to mention any kind of emotional, psychosocial impacts that breast cancer diagnosis and treatment has had on somebody. So this is, it's so interesting, but we speak to so many people that will be having sort of multifactorial reasons why they are struggling with getting on with or moving forward after a breast cancer diagnosis. So absolutely, yes, Breast Cancer Now, we have a whole range of information on our website, a dedicated booklet and information on menopausal symptoms. And it goes through, like I say, it's reassuring to hear that most of what most of you have said is something that we are sort of telling people that call us and contact us. It's about the evidence, it's about the facts, and it's about the individualized care. So yeah, by all means, please do check out our website. Oh, you're on mute.
I'm still talking on mute after 40 webinars. Many of those information is not only for patients, is very useful for clinicians. And if you can find just a link to the breast cancer website to share it on the chat function, that will be great, Jane, because not everybody is aware of breast cancer now, because lots of people are joining from other parts of the world. Maggie, you have the benefit of being a gynecologist, so you understand all those things. Not like us, we come from general surgery background. So how do you deal with patients? Let's go to the patients that have menopausal symptoms and side effects from their treatment. How do you deal with that in your clinic?
Yes, thank you, Yazan, and I hope you can all understand me despite this terrible voice I woke up with today. So yes, I'm a gynecologist and breast surgeon, and for me, it's sometimes very, very frustrating to have these patients before me that I know from the time that I have diagnosed them with breast cancer, and then they had a surgery, and now they are taking usually endocrine therapy, and they suffer. And there's not that much that you can do in terms of pharmacological approaches, but I always check our guidelines. In Germany, all of breast surgeons are actually gynecologists, so maybe this is why we have this gynecological focus. And in our breast cancer guidelines from the AGO Breast Committee, there's a special chapter on gynecological problems. And it's a very dedicated chapter, very evidence-based. I will put it in the chat right now. And then I check which approach is, how it is rated. And actually for hot flushes, for example, it's only venlafaxine, and gabapentin that are rated 1+, and the other ones are +-. So it's a very individual decision, but it's a great help in the daily practice that I can just check which approach has which rating. And it's something I would like to recommend to all of you. For me, even as a gynecologist, this is overwhelming, the amount of data that we have to deal with. And having a short list with different ratings, very evidence-based, is certainly helpful.
And that's great, Maggie. And the key point is that there's lots of things that have been mentioned by Topik and by Leah, which is great. But lots of that evidence, there's lots of points mentioned, they don't have all the same weight. So, and that's a great thing that you have the lovely guidelines from Germany that will give higher weightage for certain things that are much more safer. Am I correct in phrasing it, Maggie?
Yeah, absolutely. Actually, some of the approaches that my patients ask me about, I have never heard of. So it's really lovely to have a place where I can look them up and I can answer my patients in a more or less competent manner.
That's great. There's lots of questions on the Q&A section, but Ash, do you want to mention anything before we go on those questions?
Hi, first of all, apologies for joining in a bit late, but I had traffic issues around where I live, so got back a little later than expected. That's surgical confidence. I'll get there at 5, but took 5:10. So I think what comes out from all these talks is the fact that endocrine therapy lasts for the longest period of the patient's treatment journey. But most of us, I'm not saying all of us, most of us, when they have that conversation with patients, so we have a long conversation about radiotherapy and we have radiotherapy specific consent. We have a long conversation about chemotherapy and we have chemotherapy specific consent. We have no endocrine therapy specific consent. We're going to give you this tablet. Here's a leaflet. Read about it. It'll give you small little joint pains in the morning. It might look, give you, when you wake up in the morning, you'll be a bit late to kind of start off. It'll take a little time. Your joints will hurt. And then once you start moving, everything will be fine. Go and have this and come back. So when we're in the era of shared decision making, I mean, this is a question to the panel in general. How important do you think it is to share all these things that you guys have listed so eloquently, and the fact that they may need treatment for that? And every treatment that you guys have said come with side effects. So you're trying to treat a side effect of your treatment with more treatment that's going to give them more side effects. Because gabapentin, if you've not had it, is not a very good drug to have, but most people are on gabapentin. So it's just the fact that, let me ask Terry this question. Let's say we had given you this bleak picture of what endocrine therapy can do to you. And we gave you a choice. That's the whole concept of shared decision-making, where we tell you, this is the risk, or these are the risks with endocrine therapy, as you can see, the long list. And the benefit is a 3% survival benefit or a 4% survival benefit. It does beg the question on what patients would choose. Would they choose a quality of life, or would they say, let me try endocrine therapy. If I get all these horrendous side effects, no, thank you. I'm better off with my quality rather than quantity of life. So going back, and I'm sorry to take you back through your patient journey, Terry, how much of this information was actually shared with you before they actually gave you that prescription for tamoxifen or letrozole?
It wasn't, because we were treating the cancer. And that's a really great question that you have. My concern is this, because, as a patient advocate, I dive into this stuff. I like it, but there's many patients that don't. And in the shared decision-making process, there are patients who just want all of you to make the decision for them, but that's shared decision-making. It comes in different flavors, right? I think a lot of what this boils down to, I don't have a set pat answer for you, by the way, but I think what this really boils down to, patients are making risk analysis decisions, aren't they? They're making risk analysis. And how many patients do you know, especially after they've been through breast cancer, that are risk averse? So I think, one of the things that I guess we can all do, I'm talking to myself included when I talk to patients, is to take these studies and pull out what's specific to them. Don't fog them with the fact that, yes, we've got studies on this, we're working on this, here's what the recurrence rate is, here's what the survival rate is. And I know it takes a lot of work on your part, but really drill down to the specifics of what is affecting them. I think one thing, some of the notes that I was taking, I think one thing that you can get your staff on board with, maybe it's your nurse navigator, I don't know who it would be, but to encourage patients to do a self-assessment before they come and see you. That, I think that helps with the shared decision-making process. You know, how much is this affecting your quality of life? Is it affecting your work schedule? Is it affecting your sexual health, with your partner? Is it affecting your day-to-day living? So really kind of encourage patients to do a self-analysis, I think sometimes helps. I know this is a tremendous amount of work, but I'm just throwing out ideas because it really does boil down to risk analysis with patients, I think, and all this information. I think it's a really great question you asked, though.
No, the reason why I've asked you this question is because as a surgeon, medical legally, we even describe the risk of ALCL, which is 1 in 24,000. So any surgical complication or sequelae of surgery that would make a patient change her mind to have the surgery is by law required of a surgeon to be related to the patient. But this is what I'm saying is because of the whole journey starting from surgery, chemotherapy, patients are not even aware that these are, I mean, some patients would think these are hangover effects from, as Aglaia said, from chemotherapy. You know, this is still my hangover from the chemotherapy that I've just finished. I still have the tingling, I'm slow, I've got a fog, chemo brain. And then they don't know that most of this is accentuated by the fact that you've added to their burden of estrogen deprivation by them giving them more anti-estrogen treatment. So I take on board what you're saying.
That's great.
So, Hisham, you have your hand up, so I'll shut up for 2 minutes.
So Hisham has his hand up, and survivor issues are really not addressed well. We'll go to Hisham first for his comment and then go to the question and answer section because there's lots of questions there. Hisham, you're on mute.
Yes, actual fact, I was trying to keep quiet because I can talk all night about this. But there are, just to take on from the last point, one is that, again, we often talk about the survival benefit and we ignore the impact of recurrence on the patient's morale, and not only about just the morale, about the oncological aspect. Secondly, we tend to talk about the treatment all or none. In other words, we want to give treatment without side effects, which is impossible. And therefore, if we are actually sharing the information with the patient about side effects, there is no way that we can share it in such a way that the patient is going to say, I'm not having this treatment. Because as Terry said, we are talking about cancer. We are not talking about cosmesis. We are not talking about just the improvement quality of life. We are talking about cancer. And therefore, and my actual fact, the least of my concern about the lines of medication we give to the patient is the endocrine treatment, even if it is the longest one, because that's the one, if you cannot survive it, you will stop it and no harm done. Whereas if you go for chemotherapy, the damage is done and there is no, if you like, reversible effect. If you go for radiotherapy, the damage is done. So the least of my worry, in actual fact, is about the endocrine treatment. We need to be creative also about the regimen of the endocrine treatment. Most of us, in practical terms, we started to modify the dose of the endocrine treatment without losing the efficacy of it. We have given the patients sometimes what we call it a treatment holiday, and restarting again, we find that they seem to tolerate it second time round. We reduce the doses of the tamoxifen from 20 milligrams daily to every other day, or 10 milligrams. And there is enough evidence to say that we're probably giving the patient too much of the tamoxifen anyway. So we need to focus on how we can improve the quality of life, but without compromising the outcome of the treatment. We are dealing with cancer. The other thing which actually scares me a lot is that we started as clinicians to almost to be the guardian for the patients. If we are in our mind that we cannot use the HRT, for example, because we are worried about the side effects of it or the risk of recurrence, we don't even give the patient the choice sometimes to say, right, I am actually prepared to take some risk, but I cannot survive like this. I go to work and I cannot function. I cannot sleep. My life, there is no sex life. Some of the, I saw a woman lately who said, Mr. Hamid, I am actually going to have a divorce because I am not able to satisfy or share my sexual life with my husband. So therefore, am I going to say to this woman, not, well, in actual fact, I cannot give you HRT because the risk of recurrence? I don't think so. I need to share what we know without actually scaremongering, because from, I have a list of questions from Francesca's talk, which I've thought about before. We need to dissect also what risk we are talking about. We cannot lump everything together. Most of the problems we are facing with the menopause, we talked about the hot flushes. Yes, there are alternative treatment. We talked about, if you like, fatigue. We can do something about it. But what are you going to, is there anything at all we can do about loss of libido? Is there anything at all? We talk about severe vaginal dryness without addressing the hormone use. Is there anything at all we can do about the foggy brain, which most of the women are talking about nowadays? Yes, we can fix the osteoporosis with non-hormonal effect. We can lose weight. We can do exercises, but there are other things. There is no fix for them except that we have to face the HRT or the hormone replacement therapy, and we have to address the level of risk. And as Terry said, it has to be individualized. I do not believe for a moment that every woman who had breast cancer cannot be given HRT. We need to look at the individuals and the details of their cancer, because are we worried about local recurrence or worried about activating systemic disease? And there is a huge difference between increasing risk of a new cancer in the opposite breast as opposed to activating systemic recurrence. We need to look into this in full details, and we cannot lump all the patients with breast cancer together. And we are scared about using the hormones, which are, in my opinion, no other alternative other than the woman to say, I'm not prepared to take any risks.
Specific questions before we go to Ash. There is a couple of questions. You mentioned short-term HRT for BRCA carriers. What do you mean by short-term?
The data has shown that there is no risk for probably 3 to 4 years.
So it's up to 4 years. Now,
Correct.
And if we're talking about, because there is a couple of questions from Walid Fahmi and from Matteo Gili saying that you said that you should offer HRT for BRCA carriers. So what was the final conclusion from you? So if somebody BRCA carrier has all their symptoms, what will you offer them exactly?
Well, again, as we were talking earlier, that it depends on what symptoms they are actually complaining about. Yeah. Again, I cannot really say they have menopausal symptoms, so everybody will offer. I will offer them the HRT for symptoms which cannot be fixed by something else.
And that's all about quality of life and about risk assessment and decision making.
Correct.
Now, Francesca, beautiful meta-analysis, and you looked at mainly ER positive, and you had the subgroup of ER negative, and you showed that there is statistically no increased risk with the ER negative. Was that a lump sum of all types of HRT, or was it mainly on systemic HRT? What type of HRT we're talking about in your meta-analysis?
There is only three studies that addressed this, and it is only a subgroup analysis. So our conclusion is that this approach with the use of systemic HRT cannot be recommended in all patients with previous breast cancer.
So because some people can get the wrong message sometimes when they look at numbers. So need to be careful with that. Maggie, you had your hand up before. Did you want to mention something before we go to Hisham?
I was just going to give a short comment on the HRT in mutation carriers. At least here in Germany, our recommendation is always to replace, to give hormone replacement therapy after salpingo-ovarectomy until the age of 47 to 50
Absolutely.
in patients who do not had breast cancer, which I think is very reassuring to all the gynecologists who prescribe the hormonal replacement therapy later.
Which is great, and that's the 3 years that Hisham was talking about. Hisham,
No. Hisham, no. No. So
Ash?
I think you're confusing stuff. Maggie's made an excellent point there, which was not actually picked up by other people. Was you're actually doing the salpingo-oophorectomy to reduce risk of ovarian cancer. You're not doing it to take estrogen away, which is not the same as doing an estrogen historical oophorectomy in patients which have ER positive breast cancer. So you've now caused a precipice. You've given a cliff edge where the patient's fallen off the cliff edge rather than natural menopause. You have to understand the difference between what we are actually doing to the patient. It's caused by us, where the patient hits a brick wall and has a menopause. It's not caused for any risk reduction of breast cancer. It is for the ovarian cancer. So it's an induced menopause. And for that, you would say this patient would normally go up to 47 or 50 with her ovaries functioning. And so to reduce that risk of HRT deprivation, these women offer HRT. So it's a totally different competing risk that we're talking about. So we shouldn't get confused. The other question to Hisham before he goes off again is the reduced risk of oophorectomies that you see in BRCA carriers, which you alluded to, is seen when? Is it when they have their oophorectomy as premenopausal women or at any point in their life?
Right. The argument has been when you are offering it as a premenopausal, because that's where you are going to induce significant menopausal symptoms. But equally, the studies have looked at those who had natural menopause, because one of the things which we again, as Ash said, that we're confusing it. One of the reasons why we went there is no apparent risk from giving the HRT until the age of 50, because basically if these patients or these women did not lose their ovaries, they are already going to be producing their own hormones. So in actual fact, if anything at all, you are just resetting their level of risk to what it was. But we are equally have to address the patients who do not need oophorectomy and they have intact breasts and they are carriers of various types of the highly penetrant genes, and they've gone through the natural menopause. Again, these women, we have to consider giving them HRT, because whether you induced it or it happened by nature, you still need to deal with that. And that is where the choice of the HRT, the format, as well as the duration becomes an important to address what risk are you putting these patients for. If we're looking at all the data from the Million Women study or the WHI study, it is the duration is important. And therefore, whether there's natural menopause or not, then you are actual fact to have to observe this safety measures.
That's great. And now Peter wants to ask a question to both Tawfiq and Leah. Peter?
Yeah, thanks. Great talks. Really good session. I learned a lot. But I want to ask, what about topical progesterone for the uterus, like a Mirena coil? Do people think this is safer than systemic estrogen, systemic progesterone? Is this preferable? What's your approach if there's the patient still has an intact uterus, obviously, as part of HRT?
Well, that's tough, because there were some studies showing that it might also cause breast cancer. The thing about, well, we have to here differentiate two issues. One is risk reduction salpingo-oophorectomy. And in those cases, if you manage also to do a hysterectomy, then estrogen alone is the preferred choice. There is no doubt on that. But it was also suggested, it's not a definite answer yet, why do we need to take the uterus out? It's because in very small percentage of cases, you might end up having endometrial cancer in the long run. So that's the idea, at least for BRCA 1 and 2 carriers. So it's up to the decision, as you have been talking in the previous discussions. It's where the patient will decide whether to keep her uterus. Well, in our case, as for the gynecologist, we don't wish to have the uterus there, because we don't prescribe the progesterone supplement. And in terms of menopausal treatment, the best is the natural progesterone that we do give. And the second is dydrogesterone, which is synthetic and happens to not increase the breast cancer risk. And regarding the two initial questions that was asked earlier, when we consider risk reduction salpingo-oophorectomy for the BRCA carriers, it depends on the type, 1 or 2. One, well, in general, you would offer salpingo-oophorectomy around the age of 40, 45. But before that, we wish them to complete their families. And after they complete their families, then it's early menopause for those patients. And it is surgical menopause. And in those conditions, as you had suggested, of course, we will give HRT, and there is no increased risk there. And there are studies even looking at estrogen alone versus estrogen progesterone in these specific group of women, where the risk is not as increased as you would expect in normal postmenopausal women. And one final thing that I want to add through a gynecologist point of view is that even though the woman is not had menopausal therapy, still she has the chance of breast cancer. So we have to, when we discuss these with the patients, we have to kind of tell them their odds when they choose estrogen only and when they choose estrogen plus progesterone. It's a matter of risk assessment that should be chosen individually.
That's great. That's great, Tawfiq. Before we go to Leah for the same question, there's a couple of comments on the question and answer section about quality of life, about choice, about what are the percentages to be able to make the decision. What I do in my clinic, I always put the numbers in the predict survival tool, but that will give you just a guesstimate on what's your percentage and what's your benefit from the medication. So the discussion will be individualized with every single patient. It will be different depending on the cancer. Breast cancer is not one type of breast cancer. It's a different subtypes will have different outcomes and survivals. Leah, do you want to comment also on the same thing that Peter asked?
Yes, I'm thinking like that. It depends exactly like you mentioned now. It depends on the type of cancer. It depends on the age of the patient. It depends on what the patient wants and prefers. And then we're talking about the pro and cons every time, and we decide with the patient. We are there for the patient. But do you hear me? Yes. Yes. So I cannot just answer yes or no. It depends.
That's great. And we have Francesca, hands up.
Yes, I want to to discuss with you that from the point of view of our oncologists, that it's very important when we prescribe chemotherapy or endocrine therapy to talk about these possible side effects with the patient, because sometimes it cannot be excluded from our discussion. And sometimes I find very useful to also to print the paper by Franzoi and by Lambertini to the patient, to say that we know that endocrine therapy could have some side effect, but we have effective strategies to can help to avoid and to mitigate these side effects.
Which is great, Francesca. And if you find the link for the paper and put it on the chat function, that will be great. So people can have a look at that. That will be great. One thing is that Jane made a point that some people, the side effects will improve after a few months after they start. And sometimes people can come after a few years having joint pains, and you don't know if it's letrozole or if it's not the tablet. I always ask the patient to stop the tablet, give them a holiday for 6 weeks or 8 weeks. And then we'll see if the symptoms have improved or not, because especially some ladies can be on tamoxifen in their mid to late 40s, and then something else is kicking in. So do you do that? Maggie, do you have any comments on that?
Well, we sometimes offer the holiday from endocrine therapy. There was the SOUL study that showed that having a break of around 3 months and then again 9 months of therapy and then again a break does not compromise the effectiveness of treatment. Still, these patients have all completed 5 years of endocrine therapy without any pause before. So we cannot tell the patients that it is 100% as safe as having no breaks at all. But still, if a patient suffers, I do offer her a break of a couple of weeks just to see if it improves or not.
That's great. So everything has risks. It's all about the balance between risk and benefit. It's nearly 7:45 now here in Bordeaux. Do you have any questions? So I think Peter wants to mention something.
I'm very lucky where I am here. I get a free question for the whole panel and speakers. What do people advise about regarding vasomotor symptoms?
Sorry, say about the alcohol intake.
About alcohol intake. What do people regarding vasomotor symptoms? What are people's feelings about alcohol intake? And do you advise this as maybe an initial thing in those patients who may have a contributory effect from alcohol? I'm interested to hear the opinions.
May I? In actual fact, the patient themselves recognize the problem when they have a drink. And then you will be faced with different people. Some of them, the glass of wine is more important than the hot flushes, and the others will be the opposite. And the woman who is bothered by the alcohol, I have had patients who decided to give it up, and there is life after alcohol anyway.
So very apt question from Bordeaux, wine country. Both of you guys must. I know the camera is facing up, so the glass of wine low down ahead, but I think it's just, let's not focus on alcohol, because it's not just the alcohol that can cause it. There are triggers. There are lots of even diet-based triggers that can cause vasomotor symptoms, like cheese can cause it, coffee can cause it. So patients recognize this and then will make an informed decision themselves on whether they actually want to give it up completely, or they want to take that little beta blocker before they take the glass of alcohol, like an hour before. They'll work it out. They're very, very clever patients.
I think the alcohol came based on basis that they are in Bordeaux. So
and the cheese also is in Bordeaux. It's quite nice here in France. Now, any closing remarks, because we're coming now to 7:45. Anybody wants to put any comment, to want to mention anything? Because we have about 400 people online now, down from 500.
I want to just add something very important from my point of view, in terms of, for example, the things which there is no proven evidence that they are harmful, but we still shy away from them. Like when we talked about the Mirena coil, for example, there is very actually little evidence to say that the contribution to breast cancer is significant, because that is all related to the degree of systemic absorption. And I think that I would like to actually push the pharmacological or the pharmaceutical companies actually to be creative about producing something which can be of low systemic effect, but it gives the protection we want to do for the, for example, the uterus. We talked about various estrogen gel or estrogen cream. We know that there are the estradiol, for example, it is more readily absorbed than the estriol. All these things, actual fact, this fine tuning has to be looked at, because there is a quality of life here which we have to face, and we cannot really say to our patients, I'm sorry, this is risky, just to get on with your life and suffer forever.
Jane, you want to say something?
Mr. Hamad, I will take it upon myself to march down to the floor in the San Antonio Breast Cancer Symposium and talk to the pharmacological people and tell them to get busy on that for you, on your behalf and patients' behalf.
And Jane, you want to say something?
Just a very quick point, really, is that we do still hear on a regular basis about women who do feel that the brand of medication does make a difference to their side effects. So just really to raise that point and ask what people's opinions are briefly. I know it's short for time, but I'd be really interested to know about that, because people are absolutely convinced that the brand makes a difference.
Especially with tamoxifen, there's certain makes of tamoxifen they struggle with, and there's certain makes of tamoxifen that they don't struggle with. And we try always tell them, just try to find out which is the brand. You try different brands, and some ladies do find a big difference. If there was a study, I think from Dundee a few years ago, though, they looked only at the prescriptions and see the repeat prescriptions for ladies on tamoxifen on endocrine treatments, and nearly 50% of them were not having their repeat prescriptions just because of the side effects. So we ignore the problem and we don't try to help with the problem. The patients will not take the tablets.
Yeah, absolutely.
Jen, it was suggested that the side effect is not due to the drug itself. It is due to the carriers which they add, the additives to the drug. And therefore, yes, we hear it all the time. And as you rightly said, that we just advise the patient, stick to the brand you feel comfortable with.
I think that's what can be difficult, is actually getting the brand. Sometimes the GPs won't prescribe a specific brand, or a pharmacist don't have it in stock. So women are ringing round and round desperately trying to find that particular brand. So it's interesting to hear that. Thank you.
So Jane, can I just say that on the NHS today, I don't know where you're all practicing, but you can't get brand specific prescriptions. You get generic prescriptions. So no one knows what they're going to get from one prescription to another. It's the cheapest sourced drug that your pharmacy is going to give you. Whether like that or not, that's the truth. You can't ask for ICI tamoxifen, what we used to do before, which was the best tamoxifen that was produced. You can't ask for that anymore. So you don't know what letrozole you're getting, which part of the world it's made in, what the content is, what the purity is. And to answer your other question, Jane, is yes, certain formulations have, like Hisham said, estradiol or other forms of estrogen which have an increased risk. So yes, if they can get a specific name back to you, then you can tell them on whether that has increased risk or not. But today, best of luck trying to get that from the NHS.
So I think that we need to close. It's nearly 10 to 8. I cannot thank you all for giving up your evening and being with us tonight. It has been very useful, very informative session. It's all about decision making. It's all about weighing the risks and seeing what the patients want. So for people in the States and people in South America, have a lovely day. For people in Europe, have a lovely evening. And for people in the Middle East and the subcontinent, have a good night. Thank you, everybody.
Thank you very much indeed.
And don't hit the bar now, both of you. Behave.
We're already on the bar.
Yeah, enjoy the wine and cheese. Since you are not woman, huh?
And the hot flushes. Oh, we do get hot flushes as well.